A very good afternoon to all our viewers. Welcome to a brand new session where we are going to discuss the scope of hospital management and MPH for our doctors. Now, the field of public health mainly focuses on disease prevention and overall improvement in patients' quality of life after and before contracting a disease. So, with the knowledge of public health, physicians can definitely maximize their impact on collective health and still deliver highly, individualized healthcare. Physicians also have a greater credibility among public and peers, hence are more influential as healthcare managers, therefore promoting postgraduate courses in public health, such as Masters in Public Health and Hospital Management for Health Professionals, can strengthen healthcare sector further. For this, we have been joined by our fellow experts in community medicine specialist, Dr. Deepak Saxena, public health expert, Dr. Himanshu Negandhi, organizational behavior expert, Dr. Jallavi Panchamia, and public health expert, Dr. Dileep Mavalankar in an exclusive session here. So I would like to request Dr. Mavalankar to please start today and set context for today's discussion. Over to you, sir.
Thank you very much, Darshika, and special thanks to Doc Petrus to give us this opportunity to explain a little bit about public health and, of course, hospital management. The reason is that in India and in Southeast Asia, most of the clinical services are managed by doctors, and doctors generally are trained in providing individual care, which is very, very important for many people. It is a question of life and death when you come to a hospital or a medical facility in emergency. But we can't only depend on hospitals and medical facilities. As a society, we must also have mechanisms of preventing disease, because nobody likes to get sick and then get better. It would be much better if the society is healthy and remain healthy. And this is the job of public health. So the history of public health started with looking at how epidemics spread in a society. And given that we have just recently faced the pandemic of COVID, I don't need to tell more about what pandemics can do. But starting with understanding of how diseases spread, how diseases can be prevented, is the work of public health. And that is why it is doctors, along with microbiologists, statisticians, lawyers, social scientists, work together how to make the society healthy. And that is public health. The other side is that hospitals become bigger and bigger. They become complex organizations. And doctors who are clinical specialists or super specialists need not spend their time in managing the hospitals. That is where the discipline of hospital management arose. And now, as you know, in many big hospitals, you have non-doctor hospital managers. Of course, there are doctor superintendents and managers and non-doctor hospital managers. So both have an important and complementary role. And as we go forward, you will see that doctors will do more and more the clinical role, whereas the management role will be done by either doctors or non-doctors who have qualification in management of hospitals or hospital administration. Exactly the same thing happened in industry many years ago. Owners were running the industries, engineers were running the industry. Now, engineers along with management training are running the industry. So that transition has started happening. And that is why this today's discussion becomes very important for the doctors to understand how we can transition a clinical role to either a public health role or to a hospital manager's role.
Sure, sir. Thank you so much. And before we begin with our set of questions from our fellow colleagues here, I would like to introduce all the four speakers that we have today, our panelists for today. So let me first introduce Dr. Dileep Mavalankar, you just heard. So he's the director of the Indian Institute of Public Health, Gandhinagar, and also the vice president of West Zone and PHFI. He has been heading the IIPHG Institute since 2012. His work experience includes faculty and research positions at NHL Municipal Medical College in Ahmedabad, National Institute of Health in Bethesda, USA, Indian Institute of Management, IIM Ahmedabad, India, and Mailman School of Public Health, Columbia. Dr. Mavalankar has authored several publications and he has been an advisor to the key academic and governmental organizations and NGOs. He's also been appointed by the Prime Minister to the high-level mission steering group of the National Rural Health Mission constituted by the Government of India in 2000. He's also the member secretary of the Gujarat Government COVID Task Force. Our second panelist here is with us here is Dr. Deepak Saxena, who's currently the designated director, who will be sworning in very soon, of the Indian Institute of Public Health, Gandhinagar, currently the postdoc professor there. He is also the reputed community medicine and epidemiologist specialist. He teaches epidemiology, infectious diseases, and public health law to postgraduate students of public health and healthcare administration courses. Further, Dr. Deepak Saxena leads the Nidhi Techno Business Incubation Center, is also the member of the Regional Resource Center for the Health Technology Assessment. He's also a team member for generating evidence for the WASH in healthcare facilities at WHO headquarters. Dr. Saxena has published over 150 articles, 5 books on epidemiology, and 3 monographs. He's also the editor of the Indian Journal of Community Medicine since 2016 and heads the e-course portfolio at IIPH for over 5 years now. Welcome, sir. Our next speaker here is Dr. Himanshu Negandhi, who's the director of the academic programs at Public Health Foundation of India in Delhi. He has over 14 years of experience in public health practice and research and has served as a doctor in the Urban Metropolitan Hospital. Dr. Negandhi has taught public health to postgraduate medical students, paramedics, and in-service public health professionals throughout his career. And he's also the course coordinator for the MPH program at IIPH Delhi. And Dr. Negandhi areas of interest, expertise include public health, primary health care, assessing the supply side of human resource for health, which is called the HRH, formulating interventions for overcoming HRH shortages and research, and is also an expert in monitoring and evaluation of national public health programs. Our last speaker for today, and definitely not the least, is Dr. Jallavi Panchamia, who has over 16 years of experience in academics and research. Her areas of interest include healthcare leadership and change management, organizational behavior, and human resource management in healthcare. She's undertaken several research and consulting projects in the health sector with WHO headquarters, UNICEF, Government of India, and Government of Gujarat. Currently, she is the Associate Professor at Indian Institute of Public Health, Gandhinagar. These are all the expert speakers that we have today. So welcome to all of you. And now we would like to begin with our set of questions. So I would like to begin my first question with Dr. Mavalankar himself. So, sir, while discussing MPH for doctors, how can an interdisciplinary approach offered in MPH programs enhance a doctor's ability to address public health challenges?
Yeah. So as we become a doctor, we largely learn how diseases manifest in a person. So what is the human anatomy, physiology, pathology, microbiology, etc., and then various subjects of medicine. Whereas in public health, we understand how the diseases spread and are caused in a community. So we study the whole community. The whole community is our patient, not the individual. And that is where we have to understand the sociology of the community, the economics of the community, the water supply, sanitation, environment, air pollution, the legal structure, the health structure which is available in any society. And all of these form part of a public health curriculum. There are some of the basic disciplines like biostatistics, because we look at the population level statistics. And you must have heard so much of such statistics during the COVID pandemic. So we have to understand how they are generated, how they are compiled, how they are analyzed. We also have to understand the epidemiology, which is how epidemics spread, which are the fundamentals of public health. And then health administration, how the whole health system works, which are its components, public versus private versus NGO. And finally, how people behave, which is sociology, psychology, law, economics, etc. So that's how a public health doctor becomes much more multidisciplinary rather than looking at an individual clinical discipline. Of course, it also helps. Here it is not popular, but in Western countries, many practicing doctors on the side do a Master of Public Health to develop a better understanding of the reality of disease and health in the society where they are practicing. So you will see many public health doctors and clinical practitioners doing MPH in Western countries, and they still continue both clinical practice as well as their public health interest and research.
Awesome. Yeah. I would like to open this for the forum also, if anybody wants to add on to what Dr. Mavalankar just mentioned.
Yeah, just like to add to what Professor Mavalankar has said, multidisciplinarity also helps them to understand the disease pattern much easier. Even simple things like communication, how to communicate with patient, how to communicate with other stakeholders. So, even doctors come to know about it, and it makes them a more holistic person. So rather than looking only for secondary prevention, that's early diagnosis and treatment, they also can advise, they also can do counseling. So that is more important when we really talk about doctors learning the multidisciplinary subject of public health. So that adds value. Thank you.
Darshika, can we come in here? One of the things that really stands out in a typical public health classroom is that the eligibility criteria are broad and multidisciplinarity is encouraged in public health. All of these, whether it be the social sciences, whether it be the medical sciences, or whether it be economics, all of them play such an important role in framing an appropriate public health response. So as a teacher, it is very encouraging to see the diversity in the classroom. And this diverse mix is very much responsible for enriching the experience of individual students who join into a master's program in public health. It helps them broaden their perspective and at the same time brings in a diverse set of skill sets and discussion points into the classroom as well.
Sure. Yeah. Dr. Jallavi, please go ahead.
Oh, sorry. Yeah, please, sir.
No worries. Sorry. And also, Darshika, we are in the era of evidence-based medicine. So, even that assists a lot of doctors to actually go for an optimal treatment, learning about epidemiology, advanced epidemiology, systematic reviews, RCT, and so on and so forth. So, this multidisciplinarity, along with, some added nuances of medicine, helps them to make a much better doctor. I'll take a pause. Over to you, Professor Jallavi. Thank you.
No, I was just wanted to add, leading my example, so being engineering professional, I'm able to contribute very actively in public health. So it's there, interdisciplinarity.
Yeah, so Jallavi is a chemical engineer by training and now working on human resource management in health. So,
I think I do understand now the prospects of how and why interdisciplinary approach and also why public health in general would be important. I would now frame another question to Dr. Mavalankar to start off. If you could give me some examples of some successful research of public health initiative led by doctors with an MPH degree, I would say. How have they made a significant impact on public health at a local or national or international level?
Yeah, sure. I'll give you some of the historical examples and some contemporary examples. One of the old historical example has been a study done in London in the 1950s, you may be surprised, which compared the incidence of heart disease in two sets of people. One in Britain, if you know, in London, there were double-decker buses, which are very popular and common in London. So they compared the heart disease incidence in the conductors of the double-decker bus versus the drivers of the double-decker bus. And what they found after a 2 to 3 year study period is the drivers had much more heart disease than the conductors of the same. So they are living in the same environment, working in the same environment. Only difference is driver keeps on sitting. He has no exercise, but he is stressed. because he has to go through the London traffic. So he has a lot of stress and no exercise. Whereas the double-decker bus conductor, because there's only one conductor, he keeps on going up and down the stairs and moving front to back to collect money and tickets. So all the time he's moving around. And he has not that much stress because he's not driving through the traffic. So what it showed is two major risk factors for heart disease. One is sedentary lifestyle and stress. And second is exercise, which is a protective factor. So if you do exercise, and you will never see a bus conductor who is very fat, but the driver could be fat. So such studies done by doctors and statisticians working together on a population showed that heart disease has these two major risk factors and protective factors. And since then, we are, of course, developing more and more with cholesterol and other things being found later on. Similarly, if you see the disease studies of smoking and lung cancer or smoking and heart disease, they also were similar studies done by public health doctors to establish relationship between smoking and later on causation of cancer, heart disease. In 50s, it was a very popular and common thing for doctors to smoke because they were always under stress, and smoking was not known to be causing cancer or any disease. It was a lifestyle factor. But later on, now as it is shown, you will see very few doctors, even in India now, smoke. Earlier generation, there were a lot of smoking doctors. So in that sense, this is some of the past examples of how public health and doctors can work together. A recent example from our institute, we studied the heat wave. We are recently passing, the whole country is passing through a major heat wave. In 2010, there was a major heat wave in Ahmedabad, and our analysis working with the data from municipal corporations showed that within the Ahmedabad city, in 1 week, 800 additional deaths happened during the heat wave. Now, this is another example how public health statistics can show. Before that, people just thought that 1 or 2 people die during heat wave. You will see in the newspaper some policeman dying, some worker dying. Like in Maharashtra, recently 15 people died in this public meeting. But 800 people dying in 1 week was the first time such statistics was shown through the data in India. Of course, same thing was shown in 1995 in Chicago, which is a very cold place during heat wave of Chicago, and also in Europe. So such data-based studies can show the relationship between various factors and mortality or morbidity. And through that, we developed the Ahmedabad Heat Action Plan, which is now saving thousands of lives each summer because we have an alerting system. So if the temperature is going to go more than 45, the city alerts people, and the same action plan is now implemented throughout the country. So this is another example of how the doctors, the city government, the weather service, and a multidisciplinary team can work to prevent diseases and mortality.
Sure. Yes, sir. Dr. Negandhi, you want to add on to something to this?
Certainly, even closer home and even in recent times, we have the excellent examples of Padma Shri Dr. Abhay Bang and Padma Shri Dr. Rani Bang. They are medical doctors who have devoted their life after an MPH training as well in rural Maharashtra in a very difficult area, where through systematic research, they demonstrated how to bring down mortality among the vulnerables, particularly among children, and made sure that there was an entire ecosystem and an environment where there is a collective responsibility that comes in from communities. And that probably became a starting point for several such micro experiments towards the country. And we now see that Ashas who are doing very similar work to what was done once upon a time in Gadchiroli, spread across the length and breadth of the country. So for me, it is about, if I put it in this way, that medicine teaches us, as Professor Mavalankar was saying, to look at an individual patient. But the perspective that public health education and training brings is it expands your horizons to think about many more determining factors which are beyond the individual. And the moment you start addressing some of them, equity, access to education, access to health, and making sure that there are the right nutrition services that are available, certainly there are several disease burdens that can be reduced within the country.
Awesome. Dr. Saxena, you want to add on to some examples?
Thank you. I'm just taking forward from what Professor Mavalankar and Professor Himanshu were sharing. Very simple work done by doctors. Even during the COVID, when we started in the first wave, we were not even clear at whether we want to give hydroxychloroquine or remdesivir or tocilizumab and so on and so forth. And gradually, we developed those evidences. And believe me, during the second and third wave, maybe third wave, we're more comfortable. So a lot of work which actually were, hand washing, social distancing, all were examples that actually assisted a lot of, public health interventions, which actually assisted all of us in combating this pandemic. So I'll take a pause here. Thank you.
I think just adding on to what Dr. Negandhi also mentioned. So Dr. Abhay Wang was in fact, he was here with us last year in October to deliver a lecture and to talk about Gadchiroli, the entire district, and how they sort of started the entire work. So our audience is very well aware of them and does see them as an example setting. Yeah. Dr. Panchamia, if you want to add something to it now. Okay. So I think I would like to brief my next question for Dr. Negandhi. So, sir, talking about career opportunities, let's say an MPH degree that would open up. So, for doctors beyond a traditional clinical practice, how does it enhance their potential impact on public health and also the overall healthcare system?
I'd rather take a step backward before trying to answer this question. Because one of the things that drives people or motivates people is where they will or what they will land up doing 5 or 10 years down the line is often around money, sometimes around satisfaction or a blend of the two. Public health is very much about delayed gratification, but a big one at the end of the day. We recognize that during the pandemic, words such as epidemiology or mathematical models became very common. The newspapers were reporting them all across. So while these might be the top of the icing on the cake that you might be seeing as career opportunities that exist, broadly, we have understood that within India, when we did an analysis of close to about 5,000 graduates of public health, about 1/5 of them were working within the public sector, roughly about a similar number in the NGO or in the civil society sector. Between 10 and 15% pursued higher education, and about 25% of them went into research, and a similar number roughly into the private sector to go into consulting work. Now, while this might be the career opportunities that are available today, let me emphasize that these could be reflecting flavors of the season as to where the demand for newer jobs is at the moment. Essentially, for me, the public sector plays a very, very important role in assuring the health of citizens and populations. We have seen a very well-intentioned and excellent initiative which has been driven by the government of India under the name of the Public Health Cadre. The operational guidelines for the Public Health Cadre were released last year by the Honorable Prime Minister, and they certainly are a wonderful game-changing situation that has come up. The demand for public health within the public sector is certainly going to go up with time. So I'm seeing that there will be in the future a much greater potential for young doctors to directly work with the government as a part of the government and playing an important part in advancing the public health mandate, which has been set out in the National Health Policy. So for me, if I was a young student at this time, these are certainly exciting times that I'm seeing that the recognition and the awareness about the role that public health professions play has certainly increased. There is a greater demand for public health people and also which is emerging from the public sector.
Sure. Sir, any of you would like to add on to what Negandhi just mentioned?
Yeah, so the other side is that also there are 3 other areas emerging besides the public health side There is this whole area of health IT, which is emerging. Health data analytics, individual patient record and its management, confidentiality, etc., etc. The second area which is emerging, which is both for hospital management as well as public health people, is the startup ecosystem, which is we have one of the startup incubators, which is one of the unique startup incubators focusing on public health and health at IIPHG, which supports, we already support 30 startups in the area of public health, and individual care, as well as public health related issues. So that is the second area. The third area is overall organization and policy related to the health system. I'm not saying management of the hospitals, but how should a nation or how should a state organize its health system? How should a big company organize health system? So including occupational health, industrial health, how do we keep our workers healthy? So these are major areas which country will have to think about and is already thinking about, and future areas where public health and hospital management graduates can work beyond the typical management and public health jobs currently available in the government and NGO as well as corporate sector.
Sure. So I would like to ask a question to Dr. Deepak Saxena. So, sir, so we talked about how the entire MPH degree or public health in general would be helpful. Talking about some potential challenges, let's say barriers that doctors generally face while when transitioning from a clinical practice to a hospital management or let's say an MPH degree, how can these challenges be addressed?
Yeah, thanks. It's a good question. When PGDPHM, we usually have participants who are mid-career professionals. So something they really find it difficult is to de-learn, because conventionally they have their thought processes towards clinical care rather than looking for more holistic thing. So one challenge which I have seen among the participants, they overcome it very soon, maybe a month or so or 2 months or so, is that de-learn and relearn a new concept. Look, clinical medicine as not patient-centric, but also community-centric. So that's something which I find, and also, in a typical medical school, and I understand that majority of our participants presently are from medical background, public health is largely restricted only to what is known as community medicine, or preventive and social medicine. And that too comes on in a third semester or third first or something like that. So, they are more focused on clinical side. So talking to them about gender, about equity, about financing, they find some of these things very hard. And being from a medical background, their mathematics is even worse. So, talking about biostatistics or even simple concepts of epidemiology, but they quickly learn it. And the best part is they are able to connect it with their own practice, with their own examples. So this I feel is a challenge, but equally true is that's what they enjoy most. So that's my understanding of my classroom teaching. Professor Himanshu, if you have something to add on what are the challenges doctors usually come across. Thank you.
Certainly. I mean, one of the difficulties that we continue to face is that at a very structural level, skills in mathematics or in communication, which are extremely essential in public health, sometimes take a back seat as part of formal medical education. And these are some of the things that we need to emphasize. There are certain aspects that we need to unlearn and relearn the moment you start talking about public health. Making this shift in the thought process from thinking about an individual to a larger community is not an easy shift to make. We are used to thinking about getting an immediate solution, while in public health, we have to think about which is the most important determinant which is driving the burden of the disease. So while there are tools and techniques, while there are frameworks that help us get to it, we have to sometimes resist the temptation, being a doctor myself, to say that, okay, the immediate solution might not necessarily be the most appropriate or the correct solution. Think about it this way. It's very easy to prescribe artificial milk substitutes for babies or for newborns. But at the end of the day, there is so much of evidence that clearly shows that mother's milk is the best, and exclusive breastfeeding is the best survival tool that is available at close to negligible cost for the first 6 months of the baby's life. So it's a shift in the thought process, which is not an easy jump that every individual can make. Sometimes public health definitely brings in even slightly older people into the mix who might be working as administrators. They're important stakeholders to the public health process, but they may not have been formally trained in public health. So sometimes our young graduates who start working with older people who do not necessarily carry the same comprehensive understanding of public health, they might also have to learn the skills of negotiation, communication, and at times even conflict management, which are way outside the ambit of routine modern medicine curricula.
Awesome. I would like to hear from John if you want to add something. Yes.
Yeah, just adding what Dr. Himanshu said. He rightly pointed out that these are some of the behavioral skills that they find it challenging because earlier the scope was a bit narrow. Here, scope has been widened. If you talk about, of course, your thought process will change, but definitely it has to be reflected in your competency, overall competency. It is more of managerial that you have to divert. And here there is a scope that you will be able to contribute to a larger scope of work, and your association with different stakeholders, it makes all the more quite challenging. But I have seen it is not just a challenge, it makes the opportunity for some of the MPH graduates that I find that they not just challenging, they actually, it attracts them. So
sure, yeah. Thank you so much. Makes a lot of sense. And I think because Dr. Himanshu did talk about the public health cadre, so my question would be for Dr. Himanshu here. So what is the need for this cadre in the middle income, especially low income countries?
I think the need for a public health cadre transcends what economic bracket the country belongs to. To give a very simple illustration, in case I have a fall while walking on the road and I break a bone, I walk into the emergency and seek out somebody who has done a specialization in orthopedics. But then if there's a public health issue to be addressed, which needs a much more broader, comprehensive response, I will certainly need somebody who has got some extra training to examine the situation in its entirety, assess, do a good situation assessment, followed up by creating an inventory of the potential interventions or solutions that exist. Have the framework to identify which would be the most appropriate from a cost, from a societal acceptance, as well as an efficacy perspective, the best intervention that is available, and then have the skills to actually test them in a micro setting, then later on learn to expand it and scale it up to demonstrate the effectiveness at scale. All of it, and this life cycle of an intervention certainly takes 3, 5, and sometimes even 7 to 10 years, is very complicated and difficult to negotiate. I do not assume that somebody can just overnight develop some of these skills and approaches to create a coherent solution which is both acceptable as well as affordable. So in that sense, the public health cadre to me represents putting the right people with the appropriate skills in a position where they can make a difference. Importantly, why this cadre is very good for us as a country is because it recognizes that there is a role of that we co-produce health at the end of the day. It's an interplay between communities and health systems. So while we have the community part of it, which we are taking care of, the health system also needs to adequately respond to the needs of the community, right from the village and the block level up to the district and the state and the national level. And you will need this expertise at every single level. You'll need managerial skills. You will certainly need broader public health skills. You will need good skills in monitoring and evaluation. And if we're able to place these people within our health system, we certainly will reap the dividends from this structural reform in the next coming decade.
Sure, sir. Yeah, makes a lot of sense. Dr. Mavalankar, you want to add something to this?
Yeah. So, as Himanshu was mentioning, public health interventions are at a community, national, and city to state level. And that is why you need a very large level of thinking, organizational capacities, financial mechanisms to provide care to everybody. And that is where the social and political will to organize such services comes. One of our country's issues is that when we fall sick, we want to spend money and get our relatives or ourselves well, whatever it costs. And I'm sure you have heard, and we have heard stories of people spending up to 50 lakhs to 1 crore rupees per person for a patient to be saved from COVID. And there are cases of that type we have heard. But when it comes to a societal investment, we have to think from a very different perspective. And that is where our advocacy or our convincing skills, our evidence to the political system, to the administrators, to the health department secretary who is a IAS, or to the finance secretary if required, and to the minister is very, very important, because final such decisions of large resource allocations are made by very top levels. I'll give you one example how a top level decision has changed many things in recent times. Take the example of access to dialysis. About 5 years ago, government decided that India has very little access to dialysis. And they created a national program of 2,000 crores to set up dialysis units at almost district level. And some of the places are now having sub-district level dialysis units in the government system. So within 5 years, we moved from a place where people had to go for dialysis for long distances, wait in the queue, and then pay either in the private, to a public system. Similarly, if you see the COVID vaccination, in the nation, we never had an adult vaccination program. You may have taken vaccine just for childhood, but for adults, there was no national vaccination program. And within 1 year, we created one of the best adult vaccination programs through use of our digital technology. So it is not only public health people, but technology people also played important role. The head of that was a senior IAS officer who had worked with the government and knows how the government works. And through that, we developed this very interesting mechanism by which you could book your appointment, go get, and even certification through the cell phone. So these are the two examples when such people come together, doctors, nurses, public health people, health administrators, finance, and a national political will, then we can create such changes. And other countries have done it. It is not that we are pioneering. Britain did the National Health Service after the Second World War. They were victorious but destroyed. But after 1945, they created the British National Health System, which is one of the models. Similarly, Brazil and Thailand have created universal health care, which we are now trying to model and aspire to under various Pradhan Mantri Jan Arogya and other programs. So that is how public health and hospital sector work together to ensure health and through health development of the nation.
Sure. Dr. Panchamia, you want to add something, ma'am? Or Dr. Saxena? Else, I have a difficult question for Dr. Mavalankar here. Before we jump on to talking about hospital management courses, I would want to understand that in India, the doctor to patient ratio is so low. How would doctors leaving their clinical practice and getting into administration help the country? And I would want all of you to probably drop me a comment. So Dr. Mavalankar, I would want you to begin.
Yeah. No, I think this is a very interesting question and it comes up frequently. But we have two ends of the spectrum. Of course, overall, if you see the numbers and compare it with the WHO standard, ILO standard, we are way deficient in the total number of doctors as compared to our huge population of 1.4 billion. But if we look at some of the big cities, we have overpopulation of doctors. For example, Ahmedabad city has 88 lakh population, and just the medical association has more than 10,000 members who are practicing in Ahmedabad city, of course, including specialists and general practitioners. So that way, we don't have a good distribution. So we have shortage plus no good distribution. Plus, the doctors who work in public health are generally only 5 to 10% of the total doctors. So it is not that large percentage of doctors will go to public health. Because in a district, if you look at, say, there are 300, 400 doctors in the public system, I am saying, there may be only about 20 or 50 doctors who are in the public health as well as hospital management system. And some of the hospital managers and in some states even public health doctors do clinical practice part-time. For example, in many states, an orthopedic surgeon becomes a district health officer. That is how it is structured. Then he will continue to do his orthopedic practice in the morning and do the district health officer's work in the afternoon, evening, etc. So that is also possible. But yes, it is an issue. The other side is in India, we have not developed our paramedical workforces. For example, in many countries, a lot of work is done by nurse practitioners or clinical officers or surgical technicians or physician's assistants. These are 4 or 5 cadres which are almost non-existent or just emerging in India. So doctors who are overloaded, their work can be distributed through task shifting to many of the para-professionals. And then this issue will become less serious.
Dr. Negandhi, you want to add? Yes.
Yes, certainly. I mean, a slightly different perspective from Mavalankar sir here, but I see more reason for optimism on this front. If I quote statistics anecdotally, in the past 7 or 8 years, we have seen a near doubling of the enrollment capacity within modern medicine at the country level. The two levers that have been operated upon are, one, an increase in the number of institutions, and two, in terms of the seats that are available in each existing institution. And both of these have been touched upon, and while maintaining quality, we are able to go towards close to 100,000 enrollments per year. Now, this is a phenomenal rise that we have seen, and given that the program itself is a 5.5-year-old program, we are certainly going to see a big influx of medical doctors, well-trained doctors coming into the country. So I see reason for optimism there. Also, on the front of the microcosm that exists within the National Health Mission, the appetite for experimentation in terms of the development of towards nurse practitioners or towards a greater engagement of allied health professionals in several roles as a part of task shifting has also shown promise. I would also like to state that the Allied Health Council and the work that has happened on that in the past couple of years also is a good step that augurs well for us in order to have a very unified look at what each part of the health workforce is contributing towards the overall system. One of the things that we'll have to develop beyond the global or the WHO guidelines is in an India-specific way, given how we access our healthcare as Indians and what our demand and expectations are from care providers. what is a kind of a mixture that will be most appropriate for our population and something that we can afford as a country as well. And we will have to take those steps to making sure that the supply side, which creates all these professionals, is tuned or aligned to the overall health vision and aspirations of the country. We've made a fantastic move towards digitization in healthcare. We are talking about a greater number of people who are getting benefited from several health insurance schemes. So we need to get some of these people also trained along with our doctors, nurses, and allied professionals so that our overall system has the requisite number present at every single level within the system.
Sure, sir. Makes a lot of sense. Dr. Saxena, I think if you want to add.
No, nothing. But, I'm also in consensus with Professor Himanshu. Give us 2 or 3 years more. There has been huge impetus. Forget about MBBS. We have huge number of increase in seats for post-graduation. There are, DNB seats that has come. All diploma seats have been converted into. So it's a matter of couple of years, and we'll be soon catching up with, good numbers. Thank you. That's all.
Dr. Jallavi, you want to add?
Yeah, so most part has been covered by everyone. Just to add, I feel that having the medical background, one can contribute to various other areas also, apart from clinical. If you see, if you talk about the health education or training, healthcare infrastructure development, quality improvement, research and innovation, I feel that having the medical degree, it has got added advantage. It is crucial to maintain balance between doctors in clinical practice and those in administration. Having doctors in administration role can bring a unique perspective and expertise to address the systemic challenges and improve the overall healthcare delivery system in India. I feel so.
Sure. Yeah. So if I want to talk about, let's say, how can, collaboration and partnership between hospital management professionals and doctors with an MPH degree, how can this contribute to driving a very positive change in healthcare organizations and public health initiatives? So I think before we answer this question, I would like to talk about the hospital management professional degree, basically. So my question would be for Dr. Jallavi, ma'am. So ma'am, what are the current trends, let's say, and challenges in hospital management, and how do they impact the scope of professionals in this field?
So I feel that, when you talk about the current challenges, first of all, just let's understand that when you talk about the Master of Hospital Administration, so it is all about managing a healthcare organization. So here, when you talk about from doctor's perspective, your scope is getting changed from the one-on-one patient care to clinical care to managing whole healthcare organization. So if you talk about from that perspective, the major challenges are first is technological advancement. Because if you see the lot of automation, AI-driven technologies, so that are coming in market, and that too, use. Second, if you talk about focus is also getting changed. Earlier it was more of fee for service. Now we are actually shifting from this to value-based healthcare. So now patients are not just looking for the service or just for the charges that they are paying. They are actually looking for much more than what they were getting earlier. So that shift in that thought process is also changed. Then third, I would talk about that patient-centric care. It has been given more emphasis nowadays. That earlier focus was just to cure the patient, but now it is more of we are talking about the overall satisfaction, the patient experience in the hospital. So those things coming it as a challenge because conventionally earlier hospital management professional never thought about it, but now these are the different perspectives that we have to look for. When you talk about the different perspective, of course we have to think collaboration with the external stakeholders also. So that scope was narrow within the hospital. Now scope is getting bigger and bigger. Now you are more into collaboration with the community. So again, so that is also one of the population-based health care that you are focusing on. When you talk about the challenge, this is also as a challenge that that thought pattern has to be changed. It is not just so prevention-based focus is also one of the approach that has to be taken care of. So these are the typical challenges that hospital management professionals that might face currently, considering the trend that they are having.
Sure. Dr. Negandhi, you want to add on to that, sir? How is the situation, particularly in under your understanding, let's say if we talk about hospital management professionals?
There are three things that I would like to highlight here. Or rather, three points in terms of whenever we talk about an organization which is as complex as a hospital, hospital management professionals will certainly need a high dose of patience, perseverance, as well as the passion to actually demonstrate the work. The complexities of the environment come from two levels. One, it's the type of the caseload and the workload and the immediacy of the care that needs to be provided. And the second is about making sure that the systems in order to support the care delivery are all in place. And hospital administrators, unlike in the past where they were at the back seat, are very much in the driving seat. They're at the front of, at times, even facing the clients. And they're also at the support structures of making sure that all the inventories and the support is available for all the treating team whenever it is made done. So I think it's a role which needs a professional who has got loads and loads of patience to make sure that they are able to maintain a cool head despite all the moment-to-moment challenges that come up. The second is about the perseverance, because the hospital setting being so stressful, you have to be on it day after day and make sure that you're able to get to the results in time. And the third bit, certainly, which cuts across whether you're a doctor or whether you're a healthcare administrator, it's about passion for working in healthcare. Those three up together, and you certainly have the ingredients for a successful career in MHA.
Sure, sir. I would like to put another question for Dr. Mavalankar. So, sir, considering the increasing emphasis on cost containment in healthcare, how can hospital management professionals, contribute to financial sustainability while also ensuring the delivery of quality care?
Yeah, I think this is where the management skills come into play. Because in any hospital, the doctors who are clinically trained want the best of technology, the best of the people, the best of hospitality and accommodation, etc. But given our payment structures, the money available through the government or money available through the patient's own pockets or through the insurance is limited. And that is where the role comes saying, how do we reduce the costs and still provide quality care? And that is the, in some sense, essence of management. So delivering your quality at an affordable price. So the manager's role is to see what is really essential versus what is really not so essential but desirable. And where can we cut the corners, as to say, without compromising safety or security or the outcome or the results in terms of the patients. And there are models, and we teach these models. For example, if you take the example of Arvind Eye Hospital, which is very famous in Tamil Nadu, 4 or 5 major hospitals, they have a very interesting model where the operation theaters are in the center of the hospital. The front part of the hospital toward the road is like a 5-star, 4-star private facility with appointment and everything. The backside is for the poor patients to come at a very low cost. But finally, the treatment they get is both of them. The poor patients and the rich patients get the same treatment in the same operation theaters by the same nurses and doctors, and with similar results. So what they have done is they have mechanism or developed a strategy by which they earn patient from the paying patients who are affordable, coming from a group which can afford higher charges, and subsidize care to the poor. So the challenge is that how do we develop such models, and how do we develop mechanisms by which the hospitals get paid a reasonable amount. One of the critical bottlenecks in the current system is the costs in the private hospitals are much higher than what the government is normally paying under Ayushman Bharat. And that is where the question comes. So there are many management techniques by which one can reduce the cost without cutting the quality substantially. And that is what a hospital manager has to learn. Even proper purchasing proper management of human resources, proper management of lighting, electricity, water, etc., also can save substantial cost, and which can help reduce the burden on the patients. Second is, many hospitals which are in NGO sector also have mechanisms by which they raise funds from philanthropic donors to subsidize the patient care to the hospital, to the patient. So there are many ways by which both the quality and the cost can be balanced.
Sure. Dr. Panchamia, you want to add, ma'am?
Yeah, so just want to add further that when you talk about how MHA program, like, having health management degree can help achieving that financial sustainability in the hospital. So I feel like many competencies that, management professionals develop during this program, which can help achieving that. So, for example, revenue optimizing, then optimization of resources, operational efficiency. There are a lot of models that are being taught in operation research and project management, which helps management professionals to think aligned in that strategic objective, which is, say, for example, financial viable model that they want to develop in the hospital. In that also, cost-effective procurement, supply chain management. So these are the typical management functions that somebody can learn in order to achieve that financial feasibility or the sustainability for long run. Apart from that, performance management and data analysis, for example, somebody can establish a KPI for their staff and utilize data analysis to monitor this financial performance. They can actually align all these individual goals to the overall goal, and this is how the thinking process might, and it can really help in achieving this overall goal.
Sure, ma'am. Dr. Negandhi, any words from you? Else I have a question for you in case, yeah.
Oh, sure, we can go for the question.
Okay, so I wanted to know that what would be some, let's say, because we talk about, there are certain, in hospital care management, there would be certain skills that would be taught to you, or, discussions around it. So what specific skills or competencies, as per you, are very essential when it comes to hospital management professionals to excel in their roles? And also, how do these skills differ from those in a clinical practice?
No, I think it very much continues on the lines what Professor Mavalankar and Dr. Jallavi were saying a little while earlier, saying that it needs completely different skills which are expected. But what is the advantage that healthcare professionals bring with a prior understanding of the healthcare sector? They are able to build on with these additional competencies which a Masters in Health Administration program will provide, so that they are able to, grow these extra wings to leap to that additional distance to become better healthcare administrators. One of the things that I would also highlight is that we have to recognize that what is the kind of locus of control that exists within a healthcare administrator, within the public or the private sector. And unless we recognize what the current functions are, what their current responsibilities and powers are, and what are the expectations from them from the system, it is very difficult for us to then, as an educational institution, plan what to design or construct best for them. So in a way, my emphasis would always be that instead of looking at just the competencies which are specific to a certain issue, we should put in more and more efforts towards broad-based competencies, and the lessons of which can be taken by participants of a program from one setting and easily be transferred to the other. I mean, at the global level, McKinsey estimated that by 2035, 30% of the jobs that we know today are simply going to cease to exist. And 40% jobs are going to be such that don't even exist today. So the future is going to be something which is a little uncertain. There are other things which are changing in the external environment. Professor Mavalankar highlighted earlier about the role of AI. But are we talking about AI competencies, about handling large data, about digital records, about electronic health records, about data security? And all of this somehow is going to land up on the shoes of somebody who does hospital administration. They'll certainly not be at the fringe, but at the center stage of several of these initiatives. So while some of this change is something that we are visualizing today and we are planning for today, we'll have to be mindful that we'll have to think of some additional skills as well, which don't exist today, but make our participants lifelong learners, that even after they complete or step out of a program, they're able to equip themselves from short courses, from programs, from reading, or even for maybe listening from the media and understanding what is best expected out of them. So it's a very dynamic phase, a very rapidly changing phase that we're entering in. The situation was not like this about 25 years ago when we graduated from medicine, but today's students surely have a much more difficult task of relearning things over and over again to keep pace with what is changing. Hospital administration is certainly one such area where they will need to keep on working throughout their life.
Okay. So one question for Dr. Saxena here. So we did talk about how transitioning from a clinical to a pure public health, course would be a challenge, and also how can you overcome some challenges. But how should a doctor ascertain if, let's say, public health is the correct field for him or her? If you would like to answer.
Yeah, interesting question. Majority of us, say for like me, Professor Mavalankar, Himanshu, we all have a background of medicine. And then finally, we got culminated into what is known as public health. So, it takes some time for a person to really think about his own passion. So, I have seen many of our mid-career professional students who had come here they have been doing great in their practice, but all of a sudden they started thinking more holistically. So, my understanding is, on what are the real difficulties he have, or what is the real guiding force that will actually force him to look forward towards public health. One thing is very sure, over a period of time, maybe for the last 3 or 4 years, the trend which I have seen is in our institute, majority of the students who are coming for management or hospital administration are having a background of MBBS or having a background which is very closely who are clinical practitioner. What I have seen is, what Professor Himanshu was suggesting. In Ahmedabad, if I take a case of Ahmedabad, this local nursing home who had 4 or 5 beds have gone. If a small hospital that needs to survive needs to actually either improve in the quality or in the competencies. And therefore, there are many doctors who are coming towards hospital management rather than a conventional public health, because they already are clinicians, they already are working, and they feel that, this can give an impetus into their performance. So that's my take. But at some point of time, I'll request you for 1 minute to show 2 of our slides, maybe whenever you feel, or can I share it right now?
Yes, sir. Please go ahead. Yeah.
Sure. I'm not sure if my slides are visible or not.
Yes.
So we are Indian Institute of Public Health, and in 2007, when we were established by then Chief Minister and now Honorable Prime Minister, he envisaged that IIPG should be something like IIM and IITs of public health. And we offer a range of courses, 2 important flagship courses, Master of Public Health and Master of Hospital Administration, and also 1-year diploma, that is postgraduate diploma in Public Health Management. But what I really want to stress here is the value that IIT brings. We have an excellent relationship with national, international organization. We have knowledge MOU with top universities across globe, whether you talk about KI or whether you talk about University of Sydney, or we have been working with top-notch institutes or organization across globe, WHO, UNICEF. I really want to stress more on hospital administration, because we have been talking about hospital management, and our graduates, those who have graduated from here, they are in top hospitals presently working not only in Ahmedabad, in Gujarat, but across India. They've been working and have been very successful. And more than that, maybe Jallavi can add, all of a sudden what I have seen in last 2 years, there are many, organizations like PwC or IPE Global or data analytics or startup who have started actually hiring the hospital management graduates. So I feel, just looking only on hospital with having a background of hospital management, maybe what Dr. Himanshu was suggesting, maybe 40% of the jobs in this industry can go something beyond what is conventionally present today. So I thought I should quickly show a couple of slides to you and to the audience so that they are cognizant about what we are doing and how we are doing. And I'll hand it over to Professor Mavalankar if you'd like to add anything. Thank you.
Sure. Dr. Mavalankar, I
just quickly adding
about. So sorry. Yes, Dr. Panchamia, please go ahead.
No, just quickly adding what Deepak sir said, that, that conventional thought earlier, like when you will do, say, MPH or MHA, you will have that narrow scope. No, it's not like that. Now, if you will see the program that we are offering at IIPG, it will make you holistically, eligible for different kind of roles in different areas. So like when you talk about the current trends that you just talked about. So we are actually preparing the candidates to face those current trends, challenges which are there in the market. So IT, healthcare, consulting, these are some of the areas which were earlier public health professionals or health management professionals were not going. Now, many national level, international level health projects are there at various consulting companies which are actually looking for such kind of graduates who are having the MBBS degree basically, and then MPH or MHA, which make them eligible to apply for such big 4 companies. So I just wanted to add that. Thank you.
I would in fact request Dr. Mavalankar if you could talk about the degree and how can doctors apply and what would be the timeline we're looking at. If you could talk about it.
Yeah, sure. For the MHA program, we admit MBBS doctors and other allied professionals which are allied to health services, and they have to have the basic 1 degree because MHA is a postgraduate degree. Our timelines are 31st in the closing of the application, so very close, but it might be extended by 10 days or so. And we have a simple online application process and an interview and a short test. So that is the application process. MHA also has similar, but in MHA, any graduate can apply because that is a much more wide multidisciplinary degree. So these are the kinds of, my only advice is those doctors who are wanting really to change the society, or those who really want to play a larger role in life in organizations heading big hospitals or big health systems and have the passion to work with people to really manage them and change, should take up this type of profession, because this is basically management and administration type profession. So you have to work with people, you have to work with systems rather than with only patients. So those who are not happy with only working with the patients and see a larger role would be more fitting to such careers. Thank you.
Yeah. And if anybody wants to add in, because I would be now wrapping up, I would require all of you to probably add in your final comments about our lecture today. So Dr. Negandhi, you want to speak something, sir?
I will just probably say that the ancestor for every action that we undertake is a thought. If the thoughts of individuals are geared towards service, towards public good, Masters of Public Health and MHA programs are certainly an excellent avenue for you to reach a level of self-actualization in your life, where you see yourself, your life being committed to a very, very noble purpose. So it adds on value to the medicine and to the training that you've done, and you're able to integrate all of it together for a very large community. So that for me is an excellent proposition. Anytime anybody comes across to me, that's all I can say is that just follow what your heart tells you to do. And if your heart says that I need to work in public service, this is an excellent opportunity for you.
Thank you so much. Dr. Saxena, if you would want to add, and also if you can answer the question one of our users have put. Yeah.
So Dr. Raghavan has actually asked that what do you feel is an ideal age group for these courses? Absolutely, there is no age, an ideal age to learn something. So some of our participants, maybe around 50, 52, some of those who are passionate about learning it. So there's no upper limit or there is no upper age group. And I'd like to just tell that, our brand ambassador is right there on the screen, Darshika. She's our alumni and she's our brand ambassador for MPH. So no one else better than her can actually talk about IIPH Gandhinagar. So whatever I wanted to ask, you can directly contact Darshika also, and Himanshu has summed up very nicely. So I'll take a pause here. Thank you. I'll hand it over to Dr. Mavalankar.
Yes.
Yeah. Only thing is, I want to add that it is a full-time program. So you have to leave your whatever you are doing for 2 years and come here. So it is not a part-time or online program. We are not offering. We do have short online courses for those who want to learn more about public health or hospital management, but they are largely certificate courses. But if you want to do a degree program of MHA or MPH, both are full-time 2-year programs. Thank you.
So, Dr. Pallavi, Dr. Jallavi, if you want to add something, ma'am, I'll say.
No, nothing. I think everything has been covered. Just one thing that whosoever wants to have a very life-changing experience should take up this course, because our different pedagogical tool has made our program in such a way that you will not just learn the courses and modules that we are teaching. There are a lot of life skills also that you will learn through this program. So you can think about it positively. Thank you.
I think with this, I would like to close today's discussion. Thank you so much, Dr. Mavalankar, Dr. Deepak, Dr. Himanshu, and Dr. Ali for being here and talking about such an interesting discussion. I think it's very, very important currently, given that, public health is now playing such a big role in our country, especially after COVID. You've seen how much importance is being laid upon MHA as well as MPH courses. And thank you so much for being here and speaking to us about these courses and why and who and when should they be applying and studying these. So with this, we will close today's discussion, and thank you so much, dear audience. If you have more questions, feel free to drop it in the comment section below. Our experts here would be happy to answer. And in case you want to connect with Indian Institute of Public Health, Gandhinagar, Delhi, or any such branches, please feel free to reach out to us or Dr. Mavalankar directly. I think his details are there on our website. He would be happy to answer any questions.
Thank you. Thank you.
Thank you so much.
Our website,
Bye-bye.
It has everything.
Yes, sir.
Yeah.
Sure.
Thank you.
Thank you so much, everybody, and have a very good evening. Thank you. Bye-bye.